So we'll move right along into our next session to go from derm to sinuses. I don't know which is worse, but I'd rather do with sinuses than rashes any day for most of us. We'll talk about some of these minor things that we'll see with the ENT aspect, especially with the mouth and the nose. Anybody ever had sinusitis before? Do you feel like this? Sometimes yes, and the pressure is pretty miserable that a lot of us get. And I live in southern Tennessee, so we have tons of pollen, if you've ever been down there. So the spring is not a pretty time of the year. So we deal with a lot of this. When we talk about sinusitis, most cases are usually viral, but they do cause enough inflammation. They do get some trapped air there in those passageways, and they actually give patients a lot of pressure. It's where they tend to do the bend forward thing. It feels like their face is just going to explode. Their eyeballs want to pop out. So I can definitely relate to those and make them feel like this. But most cases are usually viral in nature. We talked about a couple of days ago, we're talking about ears and stuff. Usually it's the same things that usually cause these, but usually if their symptoms go past about 7 to 10 days, then we are worried about this could be translation into a bacterial infection. And usually that 7 to 10 days is a good mark we talk about with ENT stuff, is it gone from viral to bacterial. It's important to educate our patients that this probably is viral. Let's to treat the symptoms, let's do supportive care, and no, you don't need that Z-Pack unless we're getting past that 7 to 10 day point. They're start running that high fever or have some other comorbidities that really make us concerned more about a bacterial infection versus that true viral infection. The symptomology uses that facial pressure. They may have the drainage. A lot of them tend to get that postnasal drip. They have that P&D going down the back of their throat. They just feel like they have that just draining constantly. We may even see that on exam. We look back there and can see that exudate just kind of drain down the back of the oral pharynx. We talk about the causes. Usually it's going to be just our typical rhinovirus, adenovirus, but we talk about the bacterial causes, and that's the typical things we talk about with the ears. So staph, strep, MCATs, those are our usually biggest things that we see. Anything that's going to involve the ENT could easily be more problematic there. For the most part, treatment is purely supportive. One thing that may help a lot of people is some type of topical vasoconstrictor. So we're talking about oxymetalazone, metalazone, phenylephrine, any of those that can have a little bit of vasoconstriction, help decrease some of that swelling, may help decrease some of that inflammation, actually allow for a little bit better air passage, and actually may facilitate some of that drainage out as well. There's some studies that looked at talking about the use of some of the nasal washes. Those tend to help a little bit. They may help remove some of that mucus and some of that irritation that's up there and actually may help improve patency of some of the airways and the airflow as well. If we are concerned about a bacterial infection, then we may want to consider the use of antibiotics. Then probably augmentin, amoxicillin, clavulanic acid is probably what they're recommending too. We're seeing a good bit of the beta-lactamase producing that bacteria there, so we're going to need that a little bit of beta-lactamase inhibitor that may help a good bit. And there's always been the toss-up, how much do we treat them for? 5 to 7 days, 7 to 10 days, and probably the 3 to 7 day course is as efficacy as much as going into a 10 to 14 day course. So probably a 5 to 7 day is very effective for most people. In the pediatrics, though, we may do that full 10-day course, especially if they're in daycare, pre-K, or anywhere else where they're a breeding ground for all those other bugs that are out there with all those kids, because they're blowing their nose, snotting and sneezing, and then touching everybody else and just inoculating everybody there in the facility. We do have to worry about those complications that people talk about. They're worried about it's going to go from their sinuses up to their brain, and that definitely has a small percentage of a chance. We have to worry about, are they going to get an orbital cellulitis? Could they possibly get a meningitis with that? That definitely is a concern, but it's a very small percentage. Most of our treatment is definitely going to focus on the symptomology, treating their relief. The vasoconstrictors may help with that. The sinus washes may help with that. And then definitely if they are having some signs of bacterial infection, then treat those. And some people may even get some bronchitis-like symptoms with it, especially if they have a lot of that postnasal drip. All that chronic irritation can easily lead to some bronchitis-type symptoms, and especially our patients with asthma, that could easily lead to exacerbation of their asthma symptoms as well, just because that chronic irritation from all that drippage and drainage. And so just kind of cool little pictures to look at, those stuff that we could see. Again, very rare, but you easily could see some complications with these patients, especially if they have some type of really invasive spreading bacterial infection that wasn't treated, or they've got some kind of resistant bacteria there. But for the most part, usually these are pretty rare that we're going to see, but they do require aggressive inpatient IV antibiotic treatment with these, and definitely some consult with our experts for those cases. So foreign bodies, kids, some of our people that are a little bit mentally delayed tend to enjoy to put things in all kinds of orifices. Had that kid I mentioned the day that put a bunch of nerds in his ear. Luckily, they were in the ear and not in the nose. That would have definitely made it worse. We find all kinds of interesting stuff up in there. And sometimes it's maybe because they tell us, or especially mom and dad go, this kid's, his breath is just horrendous. And you think, oh, they could have strep, but then you look and there's something growing up in there because they shoved a bean or some type of legume or something else up in there, and it's all starting to get all nasty and snotty looking. But sometimes it may be the odor, it may be they're having some nosebleed to go along with it, or they tell you, oh yeah, put something up in there where it's an eraser or a sticker or a little toy figure or something else. But we do want to try to make sure that we get those out and definitely not cause any harm when we try to do those as well. But a history may help us. If we're worried about that chronic foreign body, that definitely probably is the one that has a really horrible odor or a really bad discharge coming out of the nair. And we talked about yesterday, we talked about esophageal swallowing of batteries, the same thing here. If it does involve one of those button batteries, we definitely have to get that out. That can be very corrosive, very erosive, and definitely cause a lot of tissue damage there in the nasal cavity, especially to the septum. So things that may help us get these out a little bit, some topical vasoconstrictors may help decrease some of the inflammation, make the passageway a little bit easier, whether we're doing some Afrin or some neosynephrine or even some topical medical cocaine may help. We're trying to stay away from the cocaine nowadays, but it may be helpful to get those things there. In kids a lot, especially, it may help to have the parents give them a kiss, or they do that blow through the mouth, and they can include the good nair and give them a good kiss and a good puff of air through their mouth. That may work and may not be as scary as actually taking the ambu bag to their face and trying to blow enough air through that, but sometimes that will work. If the parents can do it good, get a good seal, and maybe to dislodge that and pass it back through the nair, we may have to do some other things. It may even require some sedation depending on how mobile the kid is. And of course, a lot of times, usually it's the stuff that gets really soft and kind of melts, and that makes them really challenging to get out because you're up there trying to grab it, either just kind of breaks apart or your device goes into it because it's starting to get really warm and really soft and can make those very challenging. We do have several things out there. The little forceps tend to work well. The Fogarty balloon, as you see here, can help really good sometimes if you have that small enough catheter to get past. And if you don't have those, maybe if you've got a small enough Foley catheter, you could do that to get it past the foreign object, inflate the balloon, then pull it back out that way. And sometimes it gets really inventive with different devices trying to get things out, especially when they get really soft or they're one of round little beads that you can't get anything around those. Those can get really challenging as well, but the balloon does help a good bit. So epistaxis. What's the number one cause of epistaxis? Digital examination by the patient. They're up in there, they're going for it. Mom brings kid in because he's got a bloody nose, and I'm worried about foreign bodies for one thing. I said, well, he's probably picking his nose. And she's like, oh, he doesn't pick his nose. Johnny, do you pick your nose? Uh-huh. But it's usually digital trauma is the biggest thing that we think about with people. We can think about with trauma. Foreign bodies is definitely a big concern there as well. Could be related to infection, but usually it's digital trauma by the patient. We always talk about, is it the high blood pressure? Most likely not. We may see their blood pressure go up because they're having the nosebleed, but not also is it their nose is bleeding because they've got high blood pressure. But I do want to look for evidence. Are they still having a bleed even though they may not have any forward flow? Do I see it in the back of the throat? Are they swallowing a lot of that blood? As we know that blood is not the best thing on the stomach, and eventually what goes down is going to come back up, and it's not pretty when it does either way. So keep those things in mind. What are the risk factors? Do they have any risk factors for this hemorrhage? Are they on blood thinners? Are they on anticoagulants? Have they had some type of recent infection, recent procedure? Even if they're taking NSAIDs, and they're taking a whole lot of NSAIDs. I had a patient one day that was taking about 500 to 600 milligrams of aspirin every 2 hours for an ankle injury, and I'm like, dude, slow down a little bit. And he actually was having a little bit of tinnitus with it. I'm like, we can slow that down just a little bit. And his aspirin level was up a little bit. But sometimes people will overtreat themselves, not realizing the consequences, and that could easily play a role in this part of this epistaxis. So different things that we can do. Probably the best thing for most people is good direct pressure, and that works a lot for a good bit of people. The biggest thing is it takes about 20 minutes. So this, 2 minutes and it didn't work, it's not gonna last long enough. It is a good 20 minutes to get enough direct pressure for it to actually to form that clot, get a good basis for that and for it to stop, especially if we're looking at somebody who is on some of a blood-altering agent, anticoagulant or antiplatelet agent. But we're definitely needing some good bit of pressure there. But sometimes we have to do some other things. We've got some pretty good things now with the vasoconstrictors, whether we're using the same things we talked about earlier. But now we have a lot of the cool devices, the rhino rockets, the nasal tampons, the things that we used to not have 20 years ago. I can remember we used to put Foley catheters up people's nose and inflate the balloon, then tape it over their ear and send them out to see ENT. But now we've got some pretty cool things with those tampons and those nasal rockets to get, especially when we talk about the posterior bleeding, to get those under control. But usually the anterior ones are pretty easy to control. We definitely have to keep those things in mind. If we are doing some nasal packing, we're doing especially the rhino rockets, the nasal tampons for those posterior bleeds, we do have to worry about complications of those. A lot of those are really associated with people who have significant ASD disease, and I'm really worried about some erosion back there, and definitely if I put that tamponade device back there, I am going to worry about the concern of actually stimulating a vagal response and the worry for bradyarrhythmias. So a lot of these patients, we have to take that risk into consideration, and they actually probably benefit from being admitted and managed by ENT versus being sent home. And that's definitely something we need to talk with the ENT about. Look at the patient's history. Are they going to be a big risk factor for this? Because I definitely don't want them going home and having a bradyarrhythmia and having a complication from that because I did some type of nasal packing device. But there are definitely complications I have to worry about. If I do a lot of packing or some type of tamponade device, am I worrying, increasing the risk for sinusitis? Some of the stuff we talk about looks at, let's coat those things with maybe some bacitracin or some Neosporin or something to at least keep it a little bit moist in there versus preventing it from drying out and getting even more irritated and have the risk for more hemorrhage. Nasal fractures are the #1 facial fracture that we see, and the question is always, do we x-ray, do we not x-ray? Doesn't really change our plan of care. Patients sometimes do like to know, well, really, is my nose broken? Probably so. Does it really change anything? No, but a lot of us probably tend to err on the side of getting the x-ray just so we can go, yep, your nose is broke, or no, it's actually not. What we're going to do for them in the ED or even in urgent care, pretty limited. You know, we may refer them out to ENT, and sometimes they'll go ahead and want to fix it that day. Otherwise, they're going to wait till the swelling's totally gone, or if they'll do any type of reconstruction to replace that or realign that back up. But patients definitely may have some hemorrhaging with that. As we talked about earlier, they're definitely on those anticoagulants or antiplatelets, then I really have to worry about the risk for exsanguination. If I'm worried about that patient having some type of trauma, I need to make sure I look to see if they don't have a septal hematoma. If they do have that septal hematoma, I've definitely got to drain that and prevent that from reoccurring. Otherwise, we can cause some difficult deformity there to the nasal septum. And especially I want to think about what the mechanism was. If they had significant blunt force trauma, do I have the concern for basal injury? And if I'm having a lot of drainage and I need a concern, is this going to be CSF contaminated or not? So I may need to go ahead and do that halo test or that ring test. And those patients will probably definitely benefit from a CT of the head to make sure that we don't have basilar involvement, especially if I am seeing the periorbital ecchymosis. I am seeing a lot of that drainage from the nose, and the history suggests a significant traumatic impact that definitely could cause that basilar fracture. So as you see here in this picture, this patient does have a septal hematoma. Like I talked about the other day when we talked about ears with that auricular hematoma, if that blood does collect there in the septum, it's very erosive to the septum and actually will cause some significant erosion to the septum and easily can cause a significant deformity as you see here in this little kid in the very far, y'all's right. Definitely has a significant deformity there, and they'll sometimes refer to that as a saddlebag deformity. So if we've got those septal hematomas, we need to drain that, and if it reoccurs, we may have to actually do some packing up in there, like we talked about with the auricular hematoma, to keep that from recollecting and definitely get them in to see ENT, because I don't want to cause that erosion. And definitely, as you can see here, this gentleman's got both the cauliflower ear and the saddle nose deformity because of several facial trauma, I'm guessing, from boxing. But we definitely want to reassess for those and make sure if they're there, we've documented that we've corrected it, or that the absence of that. So facial lacerations, the big things I have to worry about outside of cosmetic concerns is especially where is that at in relation to some of the other facial structures, especially we think about with the parotid ducts, but also the facial nerve. As you see here, we talk about if that laceration transects this vertical line that we've got drawn here, then I definitely have to be concerned about the underlying structures. I mean, anytime with any laceration, I really want to know what the wound bed looks like. Do I have any underlying structures that are involved? But definitely for here, because if this does damage that facial nerve or does get that duct, that definitely is going to require repair, and probably for most of us, it's going to be a referral out to plastics or to ENT or whoever's covering face or something to make sure they get good repair of that. Because I don't want to miss that and then not do that repair, and then they're going to have some significant complications later from that. So facial nerve palsies, and there's several things out there we think about that could cause definitely those. One of the biggest one we think about outside of an acute CVA is definitely the worst concern for Bell's palsy. So we definitely have to concern what's going to be a peripheral origin, what's definitely going to be a central origin, and make sure that we're not missing something severe. So one of the things we think about, do they have that facial droop but they can't close their eye? Do they have the facial droop but they can't move the other part of the face? Does it affect the whole side of the face, or does it only affect part of the face? If it is Bell's that we're worried about, then usually we're going to treat those with steroids, maybe some antiviral agents if they've come in early enough within the first 48 to 72 hours. But typically with Bell's palsy, the one we see the most, they usually start with some post-auricular pain, have that pain right behind the ear. They get very sensitive to noise on that side, and people are just talking to them in normal tone. They're like, quit yelling. They have this increased sensitivity. It's usually going to affect the whole side of the face. Sometimes it even gets their taste. And like their taste feels altered. They're going to get ptosis. They can't keep their eye all the way open. They can't keep it closed. definitely going to have the risk for decreased lacrimation. And one of the things that always comes up is, is this Bell's, is this not Bell's? And one of the easiest ways I learned to keep this in mind is more is less and less is more. If more of the face is involved, it's a less severe diagnosis. If less of the face is involved, it's a more severe diagnosis. Because if it's Bell's palsy, it's going to affect the whole face, which involves the forehead. But if they're having an acute CVA that's involving the face, the forehead's spared. So if they can wrinkle their forehead, they're having an acute CVA most likely. If they can't wrinkle their forehead, then it's probably Bell's palsy. But more is less and less is more. But the way the nerve comes in and bifurcates, even with an acute CVA, the other side of the branch can control the forehead. But with Bell's palsy being an inflammatory process and not ischemic, it affects both sides of that, and they'll get full facial paralysis usually. So if the forehead's spare, that's a more severe diagnosis. That's probably an acute CVA. But if it is Bell's, usually it's going to be steroids, antivirals, definitely want them to follow up. Sometimes they may improve a little bit with some passive or active facial massage. Definitely want to educate them about eye care because they're at risk for corneal abrasions, especially at night if they can't keep their eye fully closed. So a lot of times we'll have them patch their eyes at night, do some re-wetting drops because they lose that lacrimination ability, and definitely can be very different risk, especially if they're rolling over and getting a good corneal abrasion at night. Most people resolve within a couple of weeks, but some people may have some long-term deficits, but it's not as common. But definitely want to educate them about they need to follow back up for recheck, and definitely if anything's worsening or changing. Just to reiterate here, as I talked about, if it involves the forehead, most likely that's going to be a non-central cause. We're thinking more about some type of inflammation response like Bell's palsy, but if the forehead's spared, that's an acute CVA to prove it otherwise, and definitely need to go down that track. So dental abscesses. Patients come in all the time, or at least I see them all the time, they're there for their toothache. They got the toothache, and of course I look at them going, kind of looks like meth mouth to myself. They're like, oh no, I've got bad genes. Yeah, okay, sure. But they come in, they definitely have some dental issues, and we see a good bit of dental problems with dental caries, and definitely the concern is, more than just having true dentalgia, that they actually have that dental abscess, and the concern for it actually causing some pretty significant inflammation, some pain, and concerns for other problems. But, is it right there at the tooth? Do I see the redness? Do I see the inflammation? Do I see those active cavities that look really bad? Sometimes we actually can get an x-ray, and we'll look at that in a second, and may actually see a little gas pocket there above the tooth where you actually see that apical abscess because the inflammation, the erosion there of that. Definitely, if they do have some abscess, they do have a significant amount of inflammation, we do want to treat those. A lot of times we're going to use some of our anaerobic covers. We're going to give them some Clinda or some maybe in the metronidazole, the flagyl. Those are really good for our pus formers. And these abscesses tend to be very pus producing, because they usually do involve some of those anaerobes. But penicillin plus Clinda really works well, or definitely even the metronidazole. But if we're sending them home with some flagyl, definitely good education about the avoidance of the alcohol. And some of the books even said they should have no alcohol a week prior to and up to a week after once they've taken their last dose. I don't know about out here, but that'd be pretty bad in Vegas. So you need to be absent from alcohol for a week before you even start this. But as you can see here in this film, it's got a little bit of inflammation above the tooth, but on the x-ray you can easily see the changes there above that tooth with some gas formation, definitely some signs of inflammation there on that film. And this patient may lose that tooth, but we definitely need to be a little bit more aggressive with those patients and definitely go from just doing them penicillin to probably penicillin plus Clinda, or at least something that's going to be anaerobe coverage like Clinda or metronidazole. And the one time that actually dental problems could be a true emergency is actually if they had that fracture of those avulsed tooth. So especially if we're talking about a true permanent tooth, that can be salvaged if we do it aggressively and have the right treatment access to dental access for that. Otherwise, they actually could lose that tooth. So we do want to try to treat those. And those fractured tooth, those are painful. Never had one, seen several people, but if they fracture it down to where the dentin is exposed and that nerve root's exposed, it is very painful. Just the air flowing across it is very painful for those patients. So if they've had that avulsed tooth, we want to try to put it back in place as quickly as possible. The longer it's out of socket, the longer we're going to cause more tooth damage. They want us to try to get it back in place within 30 minutes if at all possible. Now, the greatest concern is it going to stay in place? We have to worry about risk of foreign body. Are they going to aspirate on this? If it's the drunk who done fell down or DFO'd or tripped over the curb, then definitely that's a concern. If I can't put it back in place, then we can put it in milk preferably. If I don't have that, then maybe some saline or cold water. And they also talk about even putting it under the patient's gum or under their tongue if we're not worried about them actually swallowing or aspirating on that. But we do want to try to clean it off a little bit. I don't want to scrub it because I don't want to damage that ligament, but I do want to try to decon that if it's got any kind of gross contamination on it, because I definitely don't want to put it back in place that way. But I do want to try to get these patients back in to see a dental provider as quickly as possible. And one thing we can do is if they have what we actually call it dental foil, we actually is a way to wrap over that fractured tooth and actually will seal it off. And it's either calcium hydroxide and it actually gives it some protective covering, but actually will help with the pain dramatically because it prevents that air exposure, that exposed nerve root. Very painful, and that will help with their pain dramatically. And one of the last things I talk about that's really helped with these patients with their dental problems is the use of a local anesthetic, because this really does help. And see the people come out a lot, and they actually, some of them go, "Can you block me?" I'm like, "Oh, absolutely we can block you. You don't need your tabs or your perks." But patients that really are having a lot of pain, they will really appreciate doing this little apical block. And as you can see here, just bevel in towards and just going right above the tooth with a little bit of lidocaine, a little bit of marcaine, can give us some decent anesthesia and decent pain relief without doing any invasive blocks, actually doing facial blocks, and get that one tooth, and may provide them a good bit of pain relief for that tooth until they can get in to see a dental provider. And of course, for a lot of us in the ED, that gets to be the problem is trying to get someone in to see a dentist, because they come to us and they go, "We don't have a dentist on staff." You know, if we do, they're definitely not covering at 2 o'clock in the morning in the ED, but trying to get them in to see a dental provider, because they've only had this toothache for about 4 weeks, and you know, at 2 a.m. it's much worse. But I do want to make sure that they don't have any infection, because if they've got that dental infection, it doesn't get treated, and they develop Ludwig's, and that's definitely going to be a big complication. And they start getting all that anterior erythema, elevation of the tongue, those people can look pretty sick. So we do need to treat their infections if they actually do have some infection and not just dealing with dentalgia or just the dental caries. Thank you all very much. Enjoy your break.